Madam, we are live now. Shall we start?
Yeah.
So good evening, doctors and all the participants. I Shuman on behalf of Shield Healthcare, welcoming you all in today's session on a very important topic that is management of iron deficiency in pregnancy. And our guest speaker is Dr. Shamsuti Pattanaik, madam. Although madam doesn't need any kind of introduction, but it's my formal responsibility to introduce once again, ma'am. Madam did her MBBS and MS OBGN. Madam is the consultant obstetrician and gynecologist in Shanti Memorial Hospital, Rourkela, Odisha, and she is the laparoscopic surgeon and infertility specialist. So with this short introduction, I request Madam to take over the session, and meanwhile I request all the participants for your active participation, and please drop your queries on the drop box of the Shield Connect page. So once the talk will be over, we shall have a short discussion on this very important topic with Madam. So thank you very much, Madam, once again for your valuable time on our platform Shield Connect to discuss on these very emerging topics that is iron deficiency in pregnancy and how you can manage it. So thank you very much, madam, and over to you for further proceedings.
Thanks a lot to Shield Healthcare for inviting me again to have this webinar, and it's a wonderful opportunity to have a academic extravaganza always on Shield Connect, and to keep ourselves updated with the recent updates in all the topics. And it's a wonderful way to go through it, even for the senior consultants and the upcoming budding consultants. So though iron deficiency, it's a very, very common topic, and it's a very general topic, if you can say that, okay, iron deficiency, anemia, and this and that. But it is largely not properly seen, not properly corrected, and that leads to a big spectrum of problems in our day-to-day practice. But still, as it is a very small thing, it becomes a habit to ignore it. It's not only during pregnancy, it is pre-pregnancy, it's for infertility, or it's for the puberty, peripubertal age and everything. Anemia is the most important thing. It's not only pregnancy, because there are a lot of mechanisms involved in it. There is a lot of significance nowadays coming up regarding iron deficiency, anemia, and infertility also. And of course, after pregnancy, we know why is it very, very important to prevent all kinds of preeclampsia, IUGR, and other threatened abortions and miscarriages. We need to correct this thing. It's a very simple thing. Once corrected, it can lead to wonderful outcomes. So anemia, as we know, it's a quantitative or qualitative reduction of hemoglobin or circulating RBCs, or both, resulting in a reduced oxygen carrying capacity of blood to the organs and tissue. And this is the simple one-line basic pathophysiology, that is reduced oxygen carrying capacity, whether it is your spermatogenesis, oogenesis, or anything related to infertility, or premenstrual, menstrual, or pregnancy problems. Just because of this reduced oxygen carrying capacity, all of these troubles happen. So woman hematocrit 33% or hemoglobin 11 gram per deciliter in first and third trimester. Hematocrit 32% or hemoglobin 10.5 in second trimester. This is included in the definition of anemia according to CDC and WHO. So coming to mild, moderate, and very severe, ICMR and WHO, we can see the differences. Not much of a difference. 10 to 11 is mild, 7 to 10 is moderate, 4 to 7 is severe, and very severe is less than 4 according to ICMR. According to WHO, it's quite similar. 10 to 10.9 is mild, 7 to 9.9 is moderate, and less than 7 is severe. And they do not have the category of very severe. Because in India, we can have this category of very severe, because we do get people with hemoglobin of 3, 4, 5, which is not very much prevalent in other Western countries and other countries. Coming to the clinical features, symptoms: fatigue, weakness, headache, loss of appetite, dysphagia, palpitations, dyspnea on exertion, ankle swelling, paresthesia, leukoplakia, cold intolerance, irritability. These are the few symptoms, I think largely vague symptoms, that we find in our OPD. What are the various signs that we have to look for, and not the patient complaining to us? Glossitis, stomatitis, hot murmurs, increased jugular venous pressure, tachycardia, tachypnea, postural hypotension, pallor, dryness or roughness of the skin, koilonychia, dry or cracked lips, and brittle hair, out of which pallor and glossitis stomatitis is what we usually look for, and maybe sometimes tachypnea, checking the pulse. And the rest of the things are not that much elicited by us, which should be. Coming to the antenatal and lactating part of it, anemia is a major killer disease in India, and also it's not only about a killer disease regarding women and this thing, it's an underlying pathology leading to a lot of problems, as I said, regarding the menstrual problems in pre-pubertal age group, reproductive age group, and also in case of infertility, as infertility is the biggest pandemic nowadays. Again and again, I'm enforcing onto that. That is also one of the major reasons for infertility in our country. Anemia is a major, and not only in females, also male infertility, as it affects spermatogenesis. 1/5 of the maternal death is directly related to anemia. That is how important anemia is. Antenatal, as we can see here, almost 50% are anemic. Lactating, almost 58% are anemic, because once the baby is born, again the women stop their iron supplementations and calcium supplementations. Causes of high burden of anemia, as we have been reading this long back, and we know this when it comes to the medical and paramedical staff would know this: low iron stores, dietary deficiency, iron loss, and maternal anemia. So in low iron stores during pregnancy in anemic mothers, poor iron stores from infancy, childhood deficiencies, and adolescent anemia. Dietary, what is important in this? Inappropriate IYCF, especially complementary feeding practices. That is what leads to it. Excessive consumption of iron inhibitors like tea, coffee. Tea is very rampant in our country, and that is the reason why, anemia is so prevalent, especially in the all socioeconomic status, because the rich have the caffeine addiction, the poor have the tea addiction, and low intake of iron enhancers like vitamin C. As we know, deficiency of vitamin C is the reason for decreased immunity, and we know the importance of vitamin C supplementations even in a disease like COVID-19. Low bioavailability of dietary iron. 50% of the population is consuming less than 50% RDA. RDA is recommended dietary allowance. So in India, around 50% of the population is consuming less than 50%. So we can imagine what is happening in the dietary sector. Iron loss due to parasitic load, that is malaria, intestinal worms. We can see it in our village sector and other places. The huge malarial belt found in our country also, being an endemic disease. Poor environmental sanitation, unsafe drinking water, and inadequate personal hygiene. So these are the few conditions that we see here. Coming to maternal anemia, what happens in pregnancy? There is increased iron requirement due to tissue, blood formation, and energy requirement during pregnancy. Iron loss from the postpartum hemorrhage, teenage pregnancies, repeated pregnancies with less than 2 years in interval. That is also very common in our Indian setup. A snapshot of anemia in India. What does it look like? 58% of the children, 6 to 59 months, 54% of adolescent girls, 29% of adolescent boys. We are not forgetting our male partners here. 53% of women in their reproductive age, 50% of pregnant women, 58% of breastfeeding mothers. So we see the percentage is quite huge. And why anemia, why iron deficiency anemia is so important in our country. So there is a high prevalence across all the ages and slow progress in most of the states to correct anemia, or the practices for that matter. Anemia prevalence among pregnant women, as we can see here, usually 15 to 49 years age group that we can see, more than 50% is found in these 11 states and 2 union territories. As we all know, Bihar, Himachal, Jharkhand, Madhya Pradesh, Uttar Pradesh, Meghalaya, Tripura, and the other places that we can see 40 to 50% again in also Chhattisgarh, Odisha, Rajasthan, Uttarakhand. So instead of seeing this percentage, we would like to keep this in our mind that in any state possible in our country, we do have anemia. It may be 40, it may be 30, it may be 50. We all have to be careful. Why such high prevalence in India? Early onset childbearing, higher parity, which is slowly decreasing, though higher parity, and short inter-pregnancy interval. Poor eating habits, it is not only in the lower socioeconomic status, it is also in the higher socioeconomic status where a lot of unhealthy and junk food is happening and less of nutrition is going, proper nutrition is going to the body. Hookworm infestation, H. pylori infection, which is very, very common due to the outside food and everything, malaria, and hemoglobinopathies. These are also equally contributing to it. Classification of anemia, coming to physiological anemia and pathological anemia or hemorrhagic anemia. Physiological is a different thing. We know the pathophysiology will be discussed. Pathological is iron deficiency, folic acid deficiency, vitamin B12 deficiency. Hemorrhagic anemia, acute, it can be following bleeding in early months of pregnancy and antepartum hemorrhage or due to any other blood loss or hemorrhage. Chronic can be due to hookworm infestation, bleeding piles, or any other bleeding disorder in the body. Hemolytic anemia, it can be familial or acquired. Familial, it can be congenital jaundice, sickle cell anemia. Acquired, it can be due to malaria or severe infections. Bone marrow insufficiency is another cause. Hypoplasia or aplasia due to radiation, drugs, or severe infection. Hemoglobinopathies, abnormal structure of one of the globin chains of the globin. Hemoglobin molecule, that is sickle cell disease and other thalassemia and other hemoglobinopathies that we see, and sickle cell being very, very common in also in our part of the state. Coming to the physiological thing, plasma volume increases by 50% by 34 weeks, but RBC mass only increases by 25%. So we can see this disparity here. That is a basic pathophysiology. There's a disproportionate increase in plasma volume, RBC volume, and hemoglobin mass during pregnancy. So even if the plasma increases, we do not find an RBC mass increasing here. So as the pregnancy increases, we can see the blood volume increase, we can see the plasma volume increase and the red cell volume increase, out of which maximum is the blood volume, followed by plasma volume, and very less is the red cell volume. Iron deficiency anemia, it's the most common nutritional anemia. Indian women are anemic. We can just term in a generalized way that all Indian women, if you find, will find anemia in them. Sorry. It's a vicious cycle. Poverty, malnutrition was one of the causes, but nowadays, over the higher economic status and over nutrition is also important, because lack of proper essential nutrients and only junk food and all also lead to the same condition as poverty and malnutrition. Education and gender bias also playing a role. Early marriage, poor spacing, anemic mothers, that leads to anemic infants and children. Also, parasites have a big role to play. Thus, an Indian girl invariably enters a reproductive career in an iron depleted state. That is, most of the Indian women go through this vicious cycle. Coming to the prevalence of iron deficiency anemia in pregnancy, as we can see here, in India, females 15 to 49-year age group, iron deficiency anemia, we can see the percentage, it is so high. As compared to women in the global scenario, it is around just 20%, but in India, it's around 50%. So I think we should feel embarrassed or ashamed, or despite having so much education, so much advancement in science and everything in our country, and the government doing so much wonders, we are still lagging behind in correcting iron deficiency anemia in our country. So it is also our responsibility as health professionals to work for it and make our country at par with the other countries of the world. Coming to antepartum complications, why are we discussing IDA in pregnancy? Increased risk of preterm delivery, premature rupture of membranes, preeclampsia, intrauterine death, intercurrent infection, antepartum hemorrhage, congestive heart failure. Intrapartum complications, what do we have? Prolonged labor, increased rates of operative delivery and induced labor, fetal distress, abruption. Postpartum, what do we see? PPH being very common, that is postpartum hemorrhage, puerperal sepsis, lactation failure, very important. We do not give importance to this factor, because anemia can be, as I said, anemia is an underlying condition for many issues, and this is the whole spectrum what we see regarding pregnancy. As already said again, it is also the basic disorder for many basic pathophysiology for many menstrual diseases, infertility, and postmenopausal syndromes also, as the new research is telling. Subinvolution of uterus, postpartum depression also Fetal outcome, low birth weight, prematurity, infections, congenital malformation, neonatal anemia, abnormal cognitive development, increased risk of schizophrenia. So these are a few things that, how just simple correction of iron deficiency anemia can prevent the upcoming infant or the neonate from developing so many issues later in life, even schizophrenia. Who should be screened for anemia during pregnancy? All pregnant women should be screened for anemia during pregnancy, irrespective of their gestational age, at first contact, and socioeconomic status. As I said, it is not only poor, it is not only malnourished, any socioeconomic status, any gestational age, anyone coming has to be screened for anemia. Not only pregnancy, also I feel. Any gynecological obstetric disorder has to be screened for anemia. How often antenatal women should be screened for anemia? 14 to 16 weeks, 20 to 24 weeks, 26 to 30 weeks, 30 to 34 weeks. At least 4 HP estimations, which also doesn't happen in most of the cases because patients do not turn up. So any first contact, any time contact, just check the HB status. Minimum 4 times hemoglobin estimation is recommended for low risk women. However, if women has been diagnosed with anemia, she will require estimation more number of times, even just before deciding your delivery or operation, post surgery, post delivery, during lactation. So many times it can be tested to keep ourselves checked. Indications of testing serum ferritin, another important aspect, which we find many people writing due to, gaining in the lab and all that, but there has to be proper indications where you want to check your serum ferritin, not also invariably in everyone. That is prior to starting iron therapy in therapeutic doses in patients with known hemoglobinopathy. When an alternative etiology of microcytic anemia is being considered, like chronic inflammation, lead toxicity, or sideroblastic anemia. So peripheral smear also plays an important role, whether it is microcytic, macrocytic, hypochromic, hypochromic, the kind of anemia. And when we see microcytic anemia, when we are considering an alternative etiology and not just iron deficiency, there we go for serum ferritin. Suboptimal response to oral iron when compliance is doubtful, because oral iron leads to a lot of GI symptoms and constipation, which can be the reason for women not taking the tablets, also most of the times not informing the doctor. In non-anemic women at increased risk of iron depletion, such as those with previous anemia, multiple pregnancy, teenage pregnancies, pregnancy with high risk of bleeding, consecutive pregnancies with less than a year's interval. So these are the few indications that is non-anemic women, but there is an increased risk of iron depletion. We do check for serum ferritin. After 8 weeks of therapeutic iron therapy, when non-anemia iron deficiency is being treated, that is serum ferritin or 30 microgram per deciliter without anemia. So that is where we check for serum ferritin. Again, preferably prior to parenteral iron therapy to confirm iron deficiency. So it can just be a confirmation of iron deficiency before we start any iron therapy, that is oral, parenteral, or whatever. When there is a doubt in compliance, when non-anemic women, there is an increased risk, as we call it high risk category, with previous history of all these things or other risk factors that we can see. 8 weeks also after therapeutic iron therapy, when this is being treated, serum ferritin definitely can be checked. How to diagnose anemia again? History, very, very important. Examination, whatever the signs and symptoms that we have discussed, and investigations. Diagnosis. Gold standard for diagnosis of iron deficiency anemia, absence of stainable iron on bone marrow biopsy, which is not routinely done. So bone marrow biopsy indication, what are these? Failure of therapy. When we are seeing that iron is not increasing no matter what we do. Hypoplastic or aplastic anemia or color hazard. So these are the few indications where bone marrow biopsy is taken. Gold standard or 100% confirmatories when we see stainable iron on the bone marrow biopsy, which we do not do routinely. Coming to management, striking iron when it's hot. What is it? Initiating therapy, MNT, deworming, oral iron therapy, parenteral therapy, assessing the response. That is very, very important, where it is called for checking other things, alternative tests and other underlying conditions, and blood transfusion. What is the aim of initiating the therapy? To correct iron deficiency anemia, to restore the iron reserve, to correct associated complicating factor. What is the choice of therapy? How do we decide? It depends on the severity of anemia, as we have already gated it: mild, moderate, severe, very severe. duration of the pregnancy, and what are the other associated complicating factors. That also calls for choosing the therapy, whether we give an oral therapy or parenteral therapy, how much to give, what not to give. What is the basic advice on medical nutrition therapy? As we mentioned about MNT, what is the basic advice that we are going to give in MNT to the woman to improve her iron intake? We definitely advise all our women to take all this that we see in the picture, but compliance is another factor. We can see Santulit Khaye Swasth Rahe. That is what we keep on telling her. We definitely have to educate her regarding what kind of food she is going to take or consume, how many meals she is going to take, how much to take. We can educate her. We may not find all women following it, but we have to tell them. Consumption of iron-rich food. We know jaggery, spinach, pulses, eggs, liver, fish, cereals. Cooking food in iron utensils, intake of heme iron, adding ascorbic acid, that is vitamin C compounds in diet, avoiding phytates, coffee, tea intake with iron supplements. And of course, very, very important, when women take iron and calcium during pregnancy, we have to tell them to take once at one particular time of the day, maybe day or morning, the other one at other particular time, so that we do not, have this chelating substances, and we do not want the iron in calcium to form the compound and come out in the stools. We have to explain her in the local language that why she needs to take one in the morning and one in the night. Intake of iron supplements in between meals due to GI symptoms, side effects, to a reduction of that. All health facilities where food is being provided are mandated to provide fortified wheat, rice with iron, folic acid, vitamin B12, double fortified salt with iodine and iron, oil with vitamin A and D. We have been advised, but we have to make sure that the woman also takes all of this, whether it's been implemented or not. We have government doing so many things, health and family welfare doing so many things like Anemia Mukt Bharat and all those programs, but we have to make sure that the woman is eating all of this. Deworming, another very, very important thing. Anemia Mukt Bharat 2018, tablet albendazole 400 milligrams stat to all antenatal patients after first trimester, preferably in second trimester. WHO 2017, what does it say? Where hookworm prevalence is more than 20% or more, one of the following antihelminthic agents has to be given, that is tablet albendazole 400 milligrams stat, which we all give in our OPDs, or mebendazole 500 milligrams stat or 100 mg BD for 3 days. If hookworm highly endemic, prevalence 50% or more, we can repeat this antihelminthic treatment after 12 weeks of first dose. Treatment options in iron deficiency anemia, we have oral iron therapy, parenteral iron therapy, and blood transfusions. Iron supplements are the best way to restore iron levels for people who are iron deficient. Parenteral therapy is used in patients who cannot tolerate or absorb iron oral preparations, such as those who have undergone a gastrectomy, gastrojejunostomy, bariatric surgery, or other small bowel surgeries, or simply non-compliant patients who don't want to take iron. We also can give parenteral therapy in them. Or people who have faced GI symptoms or constipations who don't want to take the tablet, we can also go for parenteral iron therapy. Blood transfusions, not universal accepted approach, because blood transfusion as such has a lot of side effects and risks. But in conditions where we need rapid increase of iron for replenishment, we do have to give blood transfusions for treatment of iron deficiency anemia. Iron therapy, oral versus parenteral, we know the various side effects and the various benefits. In both of them, advantages are that oral is cheap, easy to administer, no hypersensitivity reactions. Disadvantages, again, GI intolerance, poorly absorbed, variable absorption rates, difficult in replenishing the stores quickly, and constipation and other things, as we have already mentioned, which is a very, very common side effect. Iron salts, inorganic, organic, elementary, chelated iron. The most commonly used iron supplements are inorganic, like ferrous sulfate, ferrous fumarates, ferrous ammonium citrate, or ascorbate that we usually use. We do use, but rarely, ferric polymaltose, carbonyl iron, or a ferrous biglycinate. Oral iron salts for treatment of IDA. Oral iron represents the mainstay of iron deficiency anemia, effective in major of mild to moderate cases. Common iron salts are ferrous sulfate, gluconate, and fumarate. Optimal response to oral iron is generally defined as an hemoglobin response increase of 2 grams per deciliter after 3 weeks. So So this is an optimal response, which is quite slow, but we can expect this much in oral therapy. Pharmacokinetic of oral iron requires the integrity of the mucosa of the stomach. Acidity is needed to solubilize iron. Duodenum or proximal jejunum, where most of the iron is absorbed. That is the pathophysiology basis when a person goes bariatric surgery, gastrojejunostomy, why the iron is not absorbed and why we have to switch over to a different therapy because of this reason. This integrity can be compromised by several conditions leading to malabsorption. As we said, there is various degrees of absorption in different kind of bodies in different women. Typical daily absorption of dietary iron in steady state condition is 1 to 2 milligram. Unabsorbed iron is mainly responsible of gastrointestinal adverse effects. So mucosal integrity is required, decreased pH is required for oral absorption. General instructions: take in between meals, avoid consumption with tea, coffee, milk or calcium tablets, start with low dose to decrease the side effects, change brand if intolerable, because various brands have various technologies to make it and various compositions and various salts, different kinds of salts. Different inorganic salt can also be attempted of sulfate with fumarate or ascorbate. It can be changed. Iron solution can also be used. Oral iron therapy, what are the recommendations? Prophylaxis during pregnancy, 60 milligram daily elemental iron. With folic acid, 500 microgram daily till term. This is minimum that we advise, minimum of 180 days according to GOI 2018. Treatment during pregnancy, mild to moderate anemia, we give 2 IFA tablets per day or parental iron. Severe anemia, parental iron, very severe anemia, blood transfusion. Postpartum, again 60 milligram per daily and 50 microgram folic acid for 6 months postpartum. This is what the general thing that we have, the minimum that we have to provide to the woman in any sector, public, private, government or village sector. Coming here, sulfate, fumarate, gluconate, ascorbate, carbonyl iron, bisglycinate and ammonium citrate. We see how much is it there. Elemental iron is the maximum with ascorbate and fumarate here. We see various degrees of it. Even carbonyl iron has 98 milligram per tablet. Percentage of elemental iron as calculated here, we can see the highest in carbonyl iron, followed by sulfate and fumarate. And also we have considerable good amount in gluconate and others. So as we usually prefer these things, sulfate or a fumarate, we go for it, and ascorbate is very, very good also. Oral iron, common preparations are their cheapest, most commonly used forms as already discussed. Ascorbate, what are the other things? Antioxidant effect, protects the GI mucosa, high bioavailability as already mentioned there. Most suitable for Indian diet, more inhibitors. So ferrous ascorbate is also preferred for that reason. Coming to carbonyl iron, microparticles of purified elemental iron, not as a salt, low toxicity, lesser GI side effects, absorption rate is low, permits continued release for 1 to 2 days. So these are the various advantages and disadvantages of all the preparations, and we can choose accordingly with our patients. Again here, we see in ferric hydroxide polymaltose complex, GI irritation is less, generally poor bioavailability. Most commonly used ferric salt is ammonium citrate, requires conversion to ferrous salt in the stomach, less bioavailability. So we have to see the disadvantages, and that is the reason why these are not generally used. Ferrous bisglycinate, it is not, absorption is not decreased by phytates, high bioavailability, but yes, it is costly, and amino acid chelate it is. WHO recommends ferrous form preferred over ferric because of good bioavailability, acceptable tolerability, and high effectiveness. So we recommend the ferrous form, as we have seen in all this, over the ferric form. Limitation of conventional iron preparations, again GI side effects, poor absorption, non-adherence to 75%, and time. So these are the reason why conventional iron preparations are not used, as we have already discussed. Liposomal iron, what is the recent advancement that we see? Liposomes are effective drug carrier systems which deliver therapeutic substances to specific molecular targets. Liposomes are biocompatible, low toxicity, make them suitable for delivering drugs. Iron delivery via liposomes is a promising approach. So the liposome layer is a lipid bilayer made up of phospholipids, which is similar to the biological layer. So this is the recent advancement that we have regarding liposomal iron. And why is it important? Because of its biocompatibility and less toxicity for delivering the drug, which we can find an extra for and the technology behind it. So micronized liposomal encapsulated iron passes through the stomach undamaged and unaltered. It reaches the intestinal lumen intact. Breakdown of liposomal membrane, fusion of the liposomal layer to plasma membrane of intestine with release of iron into the cytoplasm. Iron microencapsulated ferric pyrophosphate is thus directly transported in the cells. So this is the basic mechanism behind liposomal iron, how it acts and how the iron is directly transported in the cells. So better bioavailability of iron is achieved. Differences between micronized liposomal encapsulated iron and conventional oral iron, as we can see here. In liposomal iron, we do not find oxidation of iron or any food effect or any metallic taste or oxidative damage to intestinal epithelium or chelation with other metals. Even the gastrointestinal side effects are absent. Absorption of iron is enhanced and effect of gastric acidity is not there, and it surpasses that. And there is a phospholipid bilayer. So that is what liposomal iron is all about. Can oral iron given in the first trimester be given? Yes, mostly avoided due to severe gastric irritation. Can be given if indicated, endorsed by most of the guidelines, because women are highly anemic. So we can give, forgetting about our GI symptoms. Assessing the response to oral iron, increase in reticulocyte count, earliest marker of a response as early as 3 days, 1 gram HP rise in 2 weeks, 2 gram HP rise in 4 weeks, in the absence of other micronutrient deficiencies and ongoing blood loss. Suboptimal rise, we have to check the compliance, whether she's taking or not, reconfirm the diagnosis, whether it is an iron deficiency anemia or there are other reasons associated with it. And we have to consider parenteral iron if we do not see the rise. So these are the 3 things that we have to check when we do not see the increase in hemoglobin per gram or reticulocyte count. IV iron versus oral iron, again advantages, complete bioavailability, fewer GI side effects, faster recovery of HP, but increased risk of oxidant damage, increased cost, small but finite increase of hypersensitivity reaction. So we have to weigh our benefits versus risk and then go ahead about it. Parenteral iron preparations, first generation iron dextran associated with rare but serious allergic reactions that could lead to anaphylaxis. Intramuscular injection, painful staining of the buttock and require multiple injections. So these are the first generation preparations like iron dextran. Second generation like gluconate and iron sucrose only be administered in low doses because of labile or weak iron complexes. More chances of free iron release and subsequent toxicity if given in higher than recommended doses. Parenteral iron preparations, third generation. Ferric carboxymaltose, iron isomaltoside, ferrum moxitol. So FCM, as we know, it is very, very commonly used nowadays and advisable due to its unique strong complex structure, releasing much lower levels of labile or free iron, allowing larger doses of iron which can be given over shorter period of time. Prerequisites, we have to confirm that it is iron deficiency anemia, adequate supervision for management of anaphylactic reactions. You have to stop the oral iron at least 24 hours prior to therapy to avoid toxic reactions. Sensitivity testing is recommended, not required for iron sucrose and FCM, of course. We have to watch for reaction, chest pain, rigor, chills, hypotension, dyspnea, hemolysis, and anaphylaxis. So emergency tray should be ready even if we are giving a parenteral iron therapy as well as blood transfusion. Calculating dose of parenteral iron, as we know, this is the formula that we have been applying, 2.4 into target HP minus actual HP into pre-pregnancy weight in kgs. Mind here, that is where people do a mistake. We have to note pre-pregnancy weight plus 1000 milligram for replenishment of iron stores. So the target hemoglobin should be taken as 14 gram% in most of the cases. So 14 minus whatever the woman has into the pre-pregnancy weight of the woman in kg into 2.4 plus 1000. So that is why we get how much iron dose, that is in milligram, that we have to see. Accordingly, we have to decide whether 500 milligram of FCM, 2 or 3 doses we have to give, or if we are giving sucrose, iron sucrose 200, so maybe 6 times or 5 times she has to take. So that is how we are going to Decide. So indications for using IV iron in pregnancy: failure to oral iron, non-compliance or intolerance, late second or third trimester with moderate to severe anemia, malabsorption, bleeding, diastasis when hemorrhage is likely to continue, in combination with recombinant erythropoietin patients with pregnancy and chronic disease, moderate to severe postpartum anemia with compliance to oral iron and follow-up to healthcare facility is doubtful. Contraindications: lack of facilities for resuscitation, known history of anaphylaxis or reactions to parenteral iron, gestational period less than 12 weeks, known state of iron overload. So when these 4 things we find, we do not have to give IV iron. Intramuscular iron, Ministry of Health and Family Welfare recommends use of iron, IM iron after testing as a cost-effective therapy for moderate anemia in pregnancy. However, IM route has essentially been replaced by IV route due to inconvenience of the painful injection, dark discoloration of the skin, as we know, myalgias, arthritis, hypersensitivity, and lymphadenopathy. Iron sucrose versus ferric carboxymaltose. As we know here, definitely ferric carboxymaltose wins because of the various factors that we see here. In FCM, 1000 milligram in 200 ml NS over 15 to 20 minutes, whereas sucrose, we have to give multiple doses because it is only 200 to 300 milligram in 300 ml NS over 1 hour. Maximum dosage 1000 milligram per sitting can be given, but not more than 2500. But this is just 300 milligram per setting and 600 milligram per week. So low doses and a longer period of time. FCM short, less number of doses and faster recovery. Safety profile: iron sucrose wins because it is category B, but ferric carboxymaltose it's category C. Disadvantages of sucrose: multiple visits, dose limitation, thrombophlebitis. Disadvantages of ferric carboxymaltose: hypophosphatemia, high BP. Repeat dose after 3 days in iron sucrose, ferric carboxymaltose after a week. So these are the few things that we can see, and we can choose why sucrose and why ferric carboxymaltose. And usually, to be on the safer side, people do choose iron sucrose even if multiple visits are there. Iron sucrose available in a 5 ml vial with 20 milligram of elemental iron. Slow infusion of 200 milligram per dose in 100 ml NS over 20 to 30 minutes to prevent iron chelation. This has to be specifically seen and instructed to the sisters and others that it has to be over by 20 minutes because usually they keep it longer and it has no benefits and that leads to chelation of the iron. During first 5 minutes, infusion given at the rate of 20-30 drops, then increased to 80-90 drops per minute. Subsequent doses can be given over a period of 20 to 25 minutes. Too slow or too fast rates have been associated with side effects. How to assess the response? Again, improvement in symptoms, improved mood irritability in 24 hours, improved appetite, increase in reticulocyte count after 7 to 10 days, rise in HP after 2 weeks, that is around 1 gram. HP reaches normal levels by 6 to 8 weeks. If no significant improvement seen in 3 weeks, we again have to undergo evaluation and find out the cause. Finding the cause of anemia, treating the underlying cause, selecting an iron replacement product that meets the needs of the patient. So these are the challenges that we face in the management of iron deficiency anemia. It is not as easy as we found anemia, we gave the drug and it's over. No. Blood transfusion, it is the treatment of choice for immediate improvement in HB status in third trimester severe anemia. Less than 36 weeks, hemoglobin less than 5 to 7 with one or more coexisting condition. More than equal to 36 weeks, hemoglobin less than 6. Other indications for blood transfusion in pregnancy: acute hemorrhage with hemoglobin less than 6, anemia not due to hematinic deficiency, patient is in labor with severe anemia, that is hemoglobin less than 7. But again, blood transfusion has a lot of effects. It does lead to uterine contraction. So we have to again weigh the benefits versus risk. The risks of blood transfusion: each blood product transfused carries a small risk of an adverse effect. Commonest manifestations: fever, chills, and urticaria. Life-threatening reactions are hemolytic transfusion reactions, transfusion-associated sepsis, anaphylaxis, and TRALI. Recognize, respond to, and report adverse events. Indications of blood transfusion in pregnancy: with IDA, antepartum period, intrapartum, and postpartum. As we've already discussed, in case of severe anemia, less than 4, less than 5, whether less than 36 weeks or more than 36 weeks, we have to see this. Intrapartum again, in case of severe anemia. Postpartum also, anemia with signs of shock, acute hemorrhage with signs of hemodynamic instability, or less than 7 gram percentage, again, blood transfusion has to be given. Management in labor. First stage of labor, propped up position in anemic patients. We mean oxygen has to be given SOS, adequate cross-match blood has to be kept in hand, adequate analgesia, antibiotic prophylaxis in strict asepsis, monitor for signs of pulmonary edema, restrict the IV fluids. Second stage of labor, we have to cut short the second stage using instrumentation in severe anemia, strict asepsis. Third stage of labor, PPH preparedness is most important. Active management of third stage of labor, injection oxytocin, 10 international units IM is the drug of choice. Misoprostol and carboprost are safe to be used. Methyl ergometrin should be avoided. That we have to check here. Postpartum anemia. Cutoff value for anemia 1 week postpartum should be identical to the cutoff value for anemia at delivery, 11 gram percent. Anemia at 8 weeks postpartum should be defined by a hemoglobin concentration of 12 gram percentage. So the cutoff of 1 week postpartum should be identical to the cutoff value at delivery. Treatment of postpartum anemia, mildly symptomatic women, moderate anemia, we have to give IV iron, severe anemia or evidence of hemodynamic compromise, transfusion. Wherever feasible, a follow-up CBC with serum ferritin should be considered before discontinuation of iron therapy at 3 to 6 months. So we have to follow up after 3 to 6 months, check her CBC maybe with the serum ferritin, and then decide on stopping the iron therapy. The recombinant human erythropoietin has been shown to be safe and effective for the rapid correction of severe peripartum anemia in conjunction with IV iron, particularly in cases with antepartum and postpartum hemorrhage and patients with rare blood groups. So this is very, very important and can be used, and it has shown to be safe also and effective. Insufficient evidence for routine use of EPO in pregnancy, except in cases with renal disease. So though there is insufficient evidence, but in some cases it is used, EPO has been used. D or RBC parameters for IDA, what we see here, less than 3.4% indicator of IDA, less than 3.7 is also indicator. And here, what we see here, percentage of hypochromic microcytes, percentage of hypochromic reticulocytes, and reticulocyte hemoglobin content. These are the newer indicators where we can diagnose our iron deficiency anemia, and these are the cutoffs for those values. But this is again not routinely practiced, but we can definitely use this ratio of microcytic RBC percentage to hypochromic RBC percentage in differentiating IDA from beta thalassemia trait when we are not seeing optimal rise in HB. To conclude, some simple measures that work wonders. Placental transfusion, early cord clamping has to be stopped. Delayed cord clamping is the answer, 1 to 3 minutes after birth or when the cord pulsation has ceased. Cord clamping for the prevention of iron deficiency anemia in infants, it is the optimal timing that we have to consider. About 30% more blood flows into the baby and adds about 50 milligram of iron to the baby's iron stores. Nature intended babies to get their iron from placental transfusion because breast milk is not rich in iron. So that is how God has created placenta and the placental transfusion, and so that the optimum amount of blood goes to the baby, and we can prevent IDA in infants and prevent the sequelae of diseases that are going to happen throughout when the infant grows up to an adult. What is the take-home message here? Preconception counseling and detection. We have to make the woman understand that what the problem she is going through, how she is to deal with it, and how we can increase the compliance by counseling her. Screening at the first antenatal visit, repeat as and when required. Deworming, very, very important. Medical nutrition therapy, oral iron, parenteral or blood transfusion to be chosen according to the patient compliance problem and the severity of anemia. What are the other take-home messages? Smaller doses every alternate day to take with vitamin C and orange juice and lime juice and other things, not to take with we know what. with our phytates or tea or coffee and other things. It is better to take in between meals. We have to test for H. pylori if GA side effects are more. Liquid preparations, better tolerated. So we switch over to syrup or solutions also. We can cook in iron vessels or iron fish, whatever. We do a complete hemogram at booking along with serum ferritin, and a peripheral smear is also a wonderful thing to know the picture. So before I conclude, I would like to say that anemia may be a very, very common topic. We usually don't get into it. We simply write iron tablets, or we prescribe iron sucrose or carboxymaltose or a blood transfusion, give 1 or 2 bloods, but it is not that simple. We have to be very, very careful. People have lost patients in blood transfusions, in with other things. So we have to see our patient. We need to know the underlying conditions with history, with examination, and then go about to correct her anemia status, whether we want to reach a target of 11, 12, 14, whatever. But we usually what we look for is an 11 or a 12, but we do not achieve it, and most of the times, even if it's 9.6, 10, 8, we do not consider it that in an important way, and we keep on giving her iron tablets and other things. But to prevent so many problems, whether it is your IUGR or preeclampsia or premature rupture of membranes or a threatened abortion or a miscarriage or infertility for that matter, we have to correct our anemia, no matter it is an iron deficiency anemia or due to any other causes. And especially, as we mentioned here, to detect, there are newer parameters as we saw, microcytic HB percentage to hypochromic percentage, or your peripheral smear, or your HB electrophoresis, where we can detect our problem, whether it is due to other hemoglobinopathies, it's sickling, it's beta thalassemia, or any other reason, to pinpoint a diagnosis and go about the correction of anemia. So anemia is very, very important. I think we do not have to forget the issues related to it. And we have seen the importance of liposomal iron and the technology behind extra fur by Shield. So we would love to prescribe that drug and see how the rise in HB is happening in our patients, and we can help them with this oral iron tablet. Thanks a lot for this patient hearing, and I hope I could impart some messages to everyone, and people have understood a few things and cleared a few doubts. Thank you so much.
Thank you very much, ma'am, for this nice deliberation and covering entire problem and the solution of this iron deficiency anemia. So just give me 1 minute time, ma'am, to check the questions in our dashboard.
Yeah.
Thank you, ma'am. Ma'am, if you allow, then we can take the questions.
Yeah, tell me.
So, ma'am, first question is, when you recommend these iron supplements, if it is there any threshold value, then you can prescribe for that, or for all the pregnant patients after a certain period of time, you recommend iron supplements?
No, see, in OPD, I think all practitioners do that. We do write an oral iron therapy. When we check subsequently our CBCs and our hemoglobin, when we find there is no rise and all that, then we think of parenteral. Or if the lady is complaining that she's having too much acidity, bloating, constipation, she's unable to take the tablet, we do think of switching over to parenteral therapy. So basically, we do start with an oral iron tablet. Everybody does that.
Thank you, ma'am. And one thing, ma'am, as the calcium is very much needed in case of this advanced pregnancy. So, do you think that this calcium also interfere in the absorption of this iron? And
as I've already said, the lady has to be properly told, because usually when you go to a setup, we write iron calcium, the pharmacist gives the iron calcium, and the woman takes it together. Most of the cases where she's not explained, not told, I find women taking it together, and for months together, they'll be taking it together and coming and telling them nothing is happening. So we do have to tell her that she has to take at different times of the particular day, if one in the morning, one in the night, to keep at least a few hours of gap between the two tablets, so that the absorption is better.
Thank you, ma'am. And one question is, ma'am, as these oral iron supplements are existing, these are all some side effects are also associated with this, some metallic state, some feels bloating, or some other kind of issues are there. So, is there any specific parameters would you like to look forward before treating iron supplements? Is there any parameters related to the clinical symptoms or some other things related to the
Yes,
patient?
as we have already discussed, if there already some GI problems are there in the woman, we have to look for ulcers, we have to check for H. pylori infection and others, and not give oral iron in that cases. We have to, that is from the history. And when we are seeing that patient is severely anemic and she's already taken a lot of therapies earlier and it's not happening, then we have to think of whether the oral therapy is going to help or not, and various other things that we can make out from the woman and from her previous comorbidities or illness. Then we can decide that oral iron is going to help or not, or whether we are going to write her or not, and find out the real reason for anemia also, whether it is just iron deficiency and whether nutrition and supplement is going to help, or she has any other underlying pathology that can be elicited with our history itself.
Yes. Thank you very much, ma'am. And ma'am, in your practical experience, ma'am, is there any specific infection that can lead to this kind of anemia? As there is a pregnant women are vulnerable for many infections as well. So, is there any
No, as
specific
we
infection?
discussed, see, parasitic infections, hookworm infestations, H. pylori infection, these are the usual common infections that we see leading to iron deficiency anemia. So we can prophylactically prescribe women our antihelminthics and treat, the various other infections along with anemia, so that the concurrent infections, as we call it, so that the replenishment of iron is better.
Thank you, ma'am. And the last question is, ma'am, as medical nutrition therapy is also a big aspect on this iron deficiency anemia. So, what are the foods specially, and that too up to which extent? So, how can you monitor? How is it possible to monitor these food supplements or these things, or directly iron supplement is better rather than this food supplement? What is your opinion
No,
on
no,
that?
both have to go parallelly. We have to, there's nothing hard, fast and rule here. We have to tell the woman about her diet. We have to tell her about the fluids she's taking, about various other things. It is not just supplement with iron tablet that leads to the end of the story. We can tell her that 9 months is a long period of time, and whatever intake of food is there, whether she's taking, if she can help herself, if she can increase the intake of her fruits, vegetables, spinach, pulses, fish, and her other things like jaggery and all that. Nothing like it, because always natural stores, natural resources are much, much better than your chemical compounds. So, and women also prefer to do that. So 9 months is a long period of time. There is no harm in taking nutrition in the right, proper way, because not only that, it definitely helps you in other ways, and also antioxidants like our citrus fruits and all that, incorporating it, that will help in absorption of iron. So definitely it has a major role to play. Diet has a huge role to play. So we have to advise medical nutrition therapy along with iron supplements. As we say, we can never win over nature.
Thank you, ma'am. And ma'am, just another question, that is, in case of oral supplements in this anemia, so if you seen that this hemoglobin level is not significantly increased in case of oral supplements, so what are the parameters that need to check prior to give your parenteral supplements or parenteral
No,
drugs?
as we see, if we are not seeing, as we discussed about suboptimal rise, we have to check our reticulocyte count. We have to see whether hemoglobin is increasing at least by 1 or 2 gram or not in 2 to 4 weeks. That is not happening. If the clinical symptoms are not better, if the woman is besides not feeling better, she's not compliant or other things. These are the few issues where we directly shift over to parenteral iron, with checking also other parameters, as we have mentioned, to rule out other anemias like thalassemia, sideroblastic anemia, and others, doing a peripheral smear or a serum ferritin, and we decide that it's not increasing, the rise is not proper, and we shift over to our parenteral iron therapy.
Thank you very much, ma'am. So thank you very much, ma'am, for this nice presentation and this discussion on this very important topic, that is anemia in pregnancy. So thank you very much for once again for your valuable time on our platform to discuss on this very emerging topic. And as you already know that government of India has initiative of Anemia Mukta Bharat. So on that initiative also we are trying to contribute something with our new launched product, Extra. So thank you very much, madam, for your valuable time and for your valuable support also. So in future also, we will be happy to organize such a discussion, such an academic program with you in our platform. So thank you very much, ma'am.